Dr. Isaiah is the name, the NMA Vice Chairman, the Secretary of the CME Committee. I think we don't need to waste time again. We are far behind schedule. Therefore, we're going to commence the CME presentation of today. And we are going to begin with the topic, management of stroke, and that will be presented by Dr. Nuhu Abubakar, a senior registrar in neurology, Taraba State Specialist Hospital, Jalingo. So I will just begin now. Others will join us as we go on. Thank you very much. Let's pay attention. If we have any question, we can pen it down. And after the presentation, we ask appropriately. Thank you so much. Dr. Nuhu Abubakar, you have the floor.
Thank you very much. Good morning, senior colleagues and my colleagues. Welcome to today's presentation on update on the management of stroke. Please, am I audible?
Yes, sir.
Please, can you see my slide?
Yes, we can see the slide.
Okay, is it moving?
Yes.
Okay, so thank you very much. I'll be presenting it based on the following outline: definition, epidemiology, classification, types of stroke, etiology, risk factors, pathophysiology, clinical features, diagnosis, management, complications, and prevention. But we should know that stroke is a very large topic that will take days to be presented, but I'll try as much as possible to summarize or hyper summarize and present it within the stipulated time. Stroke is one of the most commonest neurological emergency and institution, especially in Nigeria, in our current situation. So they define to be a focal or global cerebral dysfunction of vascular origin lasting more than 24 hours. It comprises of cerebral infarct, abbreviated CI, intracerebral hemorrhage, abbreviated ICH, and subarachnoid hemorrhage, abbreviated SAH. Others include brain tumor and subdural hematoma. And then the transient ischemic attack. The parent term is cerebrovascular disease, but that encompasses several other conditions such as coronary artery disease, peripheral artery disease, and then the stroke itself. But when you mention CVA, cerebrovascular accident, you are referring to stroke, but also this term is no longer favored now. Okay, so we know that stroke is of vascular origin, but there are also things that can cause stroke mimics that are non-vascular, and common ones are intracranial space occupying lesions called ixon, which comprises or may comprises of hemispheric left or right hemispheric tuberculoma, cryptococoma, toxoplasmosis, cerebral lymphoma, metastatic Kaposi sarcoma, and these are commonly seen in patients with retroviral disease. So if you see any patient with weakness on one side of the body, or speech impairment, or sensory abnormality, or deviation of the angle of the mouth, or even loss of consciousness that you are thinking of stroke, you should remember this stroke mimic, and you also make sure that you screen the patient for retroviral disease. Okay, so a new concept, the definition in 2012, this 24 hours time base was said to be confusing and then misleading and outdated because it does not suggest medical emergency. It does not corroborate with the mantra of time is neuron, such as the mantra of time is heart muscle. It does not take into cognizance the use of clot in the brain vessels, which can be given within 4 and a half hours. in cerebral infarct, and then this more than 24 hours time lag does not also recognize the current use of recombinant factor 7A within 4 hours in intracerebral hemorrhage. And even the so-called TIA is not benign, because anything that lasts up to an hour is likely to be stroke, because in 90% of TIA, the symptom lasts few seconds, at most 10 minutes, and resolves within 30 minutes. But if symptoms of what you call TIA last more than 1 hour, then it's most likely to be a stroke, because chance of resolution is just 15% out of 100. So in 2013, it is said that stroke is no longer a global problem, but rather a focal problem. And then the term definition that is being given is actually secondary to considerations. When you don't have CT in your state, or MRI or CT in your facility, or when they are outdated and they are not providing adequate perfusion, CT perfusion, MRI perfusion, and it also accounts for individual variation in brain tissue viability and allows for personalized treatment beyond the traditional therapy. Hello, my slide just went off. Am I audible? So, the tissue base, because individual react to the severity of stroke differently. So in contrast to time-based onset, to the initiation of already established guidelines for the management of stroke, which use time-based approach. But we know that it doesn't account for the individual differences in stroke response and severity and tissue tolerance. This timing is because most often patients cannot tell you the exact time that the stroke developed. And then we mostly use the last time the patient was known well, especially those that were found unconscious at night. In TIA, we say that there is no objective evidence of acute infarct on imaging. And then the symptoms is just brief. But in stroke, there is objective evidence of infarction or hemorrhage. Of epidemiology, stroke is a brain attack. It's a beast, call it a monster. And there is a rule of 6 that is found in stroke, that 1 in 6 individuals will develop stroke in their lifetime. So 1 out of 8 stroke in their lifetime. So we should try as much as possible to take care of ourselves. 1/6, and 6 patients develop stroke every minute. In every 6 seconds, 1 death is recorded in favor of stroke. There is approximately 6 million deaths worldwide, and 6 million people are disabled because of stroke. Recovery is seen in 1/3 of patients. So the annual stroke globally is around 18 million. If a patient develops stroke for the first time, the chance of developing dementia is 10%, but the chance increases to 30% if the patient develops second stroke. Most often, recovery is seen within 6 weeks to 6 months. After then, it plateaus. But still, hope is not lost. People do improve beyond 6 months. Peculiarities of stroke in sub-Saharan Africa. The epidemiology of African is changing because there is currently an increase in longevity and aging population. There is a rapid population growth. There is rapid unchecked urbanization, industrialization, and accompanying lifestyle changes, such as smoking, alcohol intake, illicit drug, and physical inactivity. According to WHO 2012, that's what is called disability-adjusted life years, which is years of life lost plus years of life lived with disability due to a particular disease. And for stroke, it is 7 times higher in low to medium income countries than in the high income countries. And the global death due to stroke, it was found that currently, as of 2005, 87% of the global death is found in the low to medium income countries, such as most African countries. While the incidence is decreasing by 12% in high income countries, in our own setting, it is increasing by more than 12% over the last decades because of the exploding neglected burdens of non-communicable diseases such as hypertension, diabetes, hypercholesterolemia, and obesity, etc., and unhealthy diet. Once people stop taking the normal traditional meals that our great and grandparents were used to, and they change to taking refined food and without balanced diet and also without fiber and then sedentary lifestyle, all this culminates into stroke. Africans' ancestry, even in the high-income countries, were found to have enhanced predisposition to stroke. And they have different patterns or types or subtypes of stroke. Worse severity and often poorer outcome of stroke is seen in people of African ancestry. And they are relatively younger, less than 15 years, compared to their counterpart in the high to medium income countries. Interstroke study found that cerebral infarct occurs in 66% of people, and then intracerebral hemorrhage is 34%. And the high-income countries, majority is due to cerebral infarct, and then only 9% to intracerebral hemorrhage. But there are several studies that were done in Nigeria that shows that cerebral infarct and intracerebral hemorrhage are closing each other, almost equal with some little differences. We'll come to see about that later. Okay. African Americans, as I earlier mentioned, in the place where the treatment standard is mostly maintained, they have high predisposition, worse severity, poorer outcome compared to their Caucasian Americans. There are studies that were done in southern London. It was also found to be similar, that blacks suffer stroke the most. They have worse cognitive outcome compared to their racial whites. This could be due to some differences in variations in the rate of stroke, disparity in healthcare seeking behavior and cultural practices, and then differential access to healthcare services, and then differential exposure to environmental pollutions, adverse climate, lifestyle, and even genetic factors. So commonly, there are 3 types of stroke. The first one is this area indicating an infarct, and then this hyperdense area looking like a spider. If you see it on non-contrast CT subarachnoid hemorrhage, and this hyperdense area within the cerebral hemisphere on the left is intracerebral hemorrhage. This is dark, showing that it's a chronic infarct, but in acute infarct, it's not as dark as this. So take note. So Pathophysiology of stroke. Principally, the underlying mechanism of stroke is either ischemia or hemorrhage. Mechanism now depends on the population studied and other factors. For the ischemic stroke, Ogun, one of the done in stroke in Nigeria, found that up to 49% are ischemic stroke in Nigeria, and then 45% are hemorrhagic. While a study that was done in Abuja found that up to around 62% had ischemic stroke, and around 38% or so had intracerebral hemorrhage. For subarachnoid hemorrhage, it is just between 1 to 3%, but it's also fatal. So for the ischemic stroke, thrombosis due to arterial disease and arteriosclerosis, commonly because of hypertension, is the main culprit in over 80% of patients. But large artery stenosis, such as the carotid bifurcation, the extracranial carotid artery, and then along the major arteries from the aorta, and then other large arteries, even intracranial, they can form stenosis because of cholesterol, plaque, and so on and so forth, and then patient can develop stroke because of that. At their terminal branches, there are end arteries called small vessels. The example of them are the lenticular striate arteries. If patient develops stroke, we call them lacuna infarct. Then for cardioembolic stroke, that is emboli, that a thrombus that came from the heart, it moves to the brain and block an artery and cause stroke. The risk factors for that: atrial fibrillation, rheumatic valvular heart disease, degenerative calcific valve, which is commonly seen in elderly. When you do echo for them, you will find that some of the aortic valve are calcific. This could harbor some thrombus that can embolize to the brain and cause disease called stroke. There is also left ventricular akinesia or hypokinesia. If you do echo for your hypertensive patient or hypertensive heart disease patient, the echocardiographer will report to you that there may be wall motion abnormality or akinesia, showing that there's an evidence of ischemic heart disease. This area of hypokinesia can form clot because that area of the heart is not contracting adequately, so there will be stasis, there will be clot formation, and then there will be embolization. And then pattern foramen ovale in some rare conditions can also cause paradoxical embolo from lower limb DVT, which during valsalva maneuver, the pattern foramen ovale will allow the passage of the fragment to the left side of the heart, and then it moves to the brain. Rarely, fat embolism from fractures, air embolism if it is large volume of air, and then atrial myxoma, which is a heart intracardiac malignancy, intracardiac mass called atrial myxoma in the left atrium, can also form part of it could detach and then embolize to the brain. One of the common causes of ischemic stroke, which were also culprit at times, is the hypoperfusion secondary to severe hypertension. Maybe you are giving the patient the first dose of anti-angiotensin converting enzyme inhibitor. I didn't ask him to take a low dose at the starting period, and then maybe it was not given at night. So if patient can develop hypertension during sleep and develop ischemia. And if it's during the day, patient can collapse. And whatever cause of hypoperfusion, be it a cardiac coronary artery disease such as acute myocardial infarction, or due to cardiac arrest from whatever cause, including anesthesia, all this could lead to cerebral hypoperfusion and lead to cerebral ischemia. For the intracerebral hemorrhage, the common pathophysiologic mechanism for the hemorrhagic stroke are the ICH and the subarachnoid hemorrhage. And then also here, hypertension is also one of the main culprits, but there are others, including smoking, because of its effect on the vasculature. And then sometimes alcoholic binge, large volume of alcohol at a go, can also lead to cerebral hemorrhage. Then other determining causes, they are rare causes, but they are many, and they include uh, things like antiphospholipid syndrome, things like pulmonary AV fistula, and then so on and so forth. And then there's also what is called CADASIL and MELAS. These are cerebral autosomal dominant arteriopathy and subcortical infarct and leukoencephalopathy. They used to ask it in exam at various levels. So it's also a form of genetic cause of stroke. And some stroke can be cryptogenic, whereby there are no identifiable causes found. So call it cryptogenic or undetermined. For the subarachnoid hemorrhage, the common cause is a rupture of intracranial aneurysm, commonly berry or circular aneurysm, often due to hypertension, atherosclerosis, genetic or trauma. They ask this in the exam also. And the other less common cause is non-aneurysmal subarachnoid hemorrhage, which could be because of trauma, such as RTA, intravenous inflammation, vasculitis, tumors, and then abuse of recreational drugs, such as cocaine and amphetamine. And there is also another risk factor for stroke that we should also not forget. These symptomatic agents that are found in cough syrup, cold catarrh tablet, sometimes they can cause vasospasms or vasoconstrictions in the cerebral arteries and also cause stroke.
Package per hour, not micro.
So for the intracerebral hemorrhage, also anticoagulant that we give for different indication can also cause bleeding. DIC from whatever cause can also lead to intracerebral hemorrhage. Okay, so this is the Oxford and Bamford classification of stroke. Why the classification? Because it is good for therapeutic decision making in daily practice. It describes patients' characteristics in daily practice and clinical research, and it allows for grouping of patient epidemiologic research and the careful phenotyping in genetic studies. So whenever you develop stroke, it's important to try to classify it. And the Oxford classification classifies stroke into total anterior circulation, partial anterior circulation stroke, posterior circulation stroke, or lacuna strokes. For the total anterior circulation stroke, what you need for diagnosis is when patient present with weakness on one side of the body and or sensory loss, that is in the face, arm, or leg, and he has visual problems such as homonymous hemianopia, right or left, and then other symptoms such as dysphagia or inability to recognize places. So for total anterior circulation stroke, which are large cortical stroke involving the middle and or anterior cerebral arteries, you need these three for diagnosis. For partial, you need two. For posterior circulation, supplies the brainstem and the cerebral hemisphere, the cerebellar hemisphere. So you need cerebellar signs, and then you need one of the cerebral signs or brainstem syndromes, or there could be loss of consciousness or isolated homonymous hemianopia. For the cerebellar syndromes, things like staggering gait, incoordination, tremor when you are reaching out to object or you are trying to take a cup of tea, you develop tremor, hypertonia, nystagmus, abnormal eye movements, and then other symptoms of cerebral. This darkokinesia will be positive, and then other symptoms of cerebral abnormality will also be there. And then things like dizziness, vertigo, they are all features of posterior circulation. For the lacuna, in fact, I've earlier mentioned that these are the lenticular striate arteries, they are end arteries. If they are involved, patient present with lacuna syndrome with pure motor, pure sensory ataxia, hemiparesis, and what have you. So this classification is based on symptoms. If you don't have CT, use the symptom to know the types of stroke and to know how to approach how to approach the stroke. And then one other advantage of this classification is that it predicts the extent of the stroke. It gives the potential area affected and the underlying cause, and also good for prognostication. Okay, so there are several risk factors for stroke. There are non-modifiable and modifiable factors. And the non-modifiable factors, those that we cannot modify, are the age, the gender, the genetic. Genetic is potentially modifiable, and also family history of stroke. We can't change that. Okay, for the behavioral risk factors, which are also modifiable, are tobacco, alcohol, diet, sedentary life, and then socioeconomic, sociocultural, environmental conditions, environmental pollutions, household air pollutions, biomass fuel, even from cooking with firewood in the tight kitchen without window over years, can predispose somebody to stroke. And then ambient particulate matters, such as in desert area where the particulate matters in the air is too much, that can also cause, it's a risk factor. But the major risk factors we all know are the hypertension, the dyslipidemia, the diabetes, and then diabetes, both fasting blood glucose and both fasting and postprandial can also cause a cardiovascular burden and then lead to stroke. So we are measuring fasting blood sugar commonly, but those that have impaired postprandial hyperglycemia can also develop stroke. The risk factor for stroke and other cardiovascular disease is the same with both fasting. So we should be doing HbA1c at least every 6 months or once in the year for diabetic patients. So this lipidemia, atrial fibrillation, which is called because of increased prevalence of congestive heart failure with atrial fibrillation, commonly in the elderly, and then obesity, severe carotid stenosis, if it is more than 70%, is also risk factors for most commonly TIA and then subsequently for stroke. And then there are also, this is how to classify them based on biological factors, social factors, and genetic factors. For genetic sickle cell disease, inherited thrombophilias, and then the cardiac cell are mentioned. For social factors, even access to care, systemic discrimination, and then his historical exclusion from research. Because if people participate in research, they tend to benefit from the outcome of the research in the form of intervention and whatever, and also follow monitoring. So in people whereby research is not done adequately in their population, they try to miss. And then some provider biases, whereby some patients are treated far better than other patients. Also stigma, and then commoner in the advanced country, but also in our own healthcare setting is also common. And this has to do with sometimes attitude of the physician attending to the patients. Trust in healthcare system also. When the population don't trust the healthcare system, they don't want to come to the hospital on time. And they will be patronizing other people who should be detrimental to their health. So the new additional risk factors are electronic cigarette, now the e-cigar, the obstructive sleep apnea I mentioned, and then most importantly, SARS-CoV-2, the COVID era, and then the COVID infection is also a risk factor for stroke. And then infections such as HIV, cytomegalovirus, even chlamydia, pneumonia, Helicobacter pylori that most of us are having, herpes simplex virus, periodontal disease, people that don't take care of, don't have dental hygiene. It's also a risk factor for not only stroke, but also a risk factor for dementia. Okay. Globally, 90% of stroke is attributable to modifiable factors, those that I mentioned, which we can change. And then some clusters of behavioral, metabolic, and environmental risk factors as well. In terms of some of the etiologies, also for intracerebral hemorrhage, that's what is called cerebral amyloid angiopathy, which is common in people above 60 years. These people are not hypertensive, but they tend to have recurrent lobar hemorrhage due to amyloid deposition in their blood vessels. So if you see a hemorrhage in the lobes of the brain and it's recurrent, then it's also important to rule out cerebral amyloid angiopathy, especially the patient is 60 years and more than 60 years. Some of the neoplasms can also cause intracerebral hemorrhage. I mentioned coagulation disorder, systemic disease, AV malformation, cocaine, amphetamine, and then NSAIDs too can also cause that. Okay. And then other traditional risk factors including the age, male sex, hypercholesterolemia, low cholesterol generally can predispose to intracerebral hemorrhage. So as you are correcting, you should be monitoring also. Alcohol abuse has variable relationship with subarachnoid hemorrhage in particular, where the relationship is linear in subarachnoid hemorrhage. But for the intracerebral hemorrhage, it is U-shaped. Means the higher you, if you take a large volume, you tend to develop intracerebral hemorrhage for people that have maybe other predisposition. Why, if the volume is less, the frequency is less. If the patient return to large volume of ethanol ingestion, then the risk will increase. But for the cerebral infarct, it is J-shaped. So it is like sustained intake of ethanol over years that can predispose person to cerebral infarct. So intake of illicit drug, diet high in salt and saturated fats, low potassium, polyunsaturated fatty acids, and then physical inactivity, stressful life event. The current stress people are going through is contributing to the increased risk of stroke, both ischemic and hemorrhagic, and also low socioeconomic class is also a risk factor for stroke. So, but there is what we call cerebral autoregulation. The average cerebral blood flow is 55 ml per 100 grams of brain tissue per minute. The gray matter takes large amount while the white matter takes less. So the total brain constitutes only 2% of total body weight, but it took 20% of blood volume. With each cardiac output, the brain takes 20% of that cardiac output and 20% of oxygen. There is this formula that we all know about cerebral
What is going on?
Sorry, how much? So whenever you have occlusion in the cerebral blood vessel or in the capillaries or arterioles without collateral circulation, then stroke is bound to happen and is likely to be severe. Some of the collateral circulation that the brain has in trying to avert stroke are primary, such as circle of Willis, secondary, such as between ophthalmic artery and leptomeningeal arteries, and then new vascularization and angiogenesis, which there are certain drugs that can help with new vascularization and angiogenesis, such as the NeuroAids and other tocotrienols. So whenever you have occlusion in the absence of adequate collateral circulation, then stroke will happen and it will be likely to be severe. Okay, and then high blood pressure with lipohydrolysis leading to Charcot Burkert aneurysm and even microatheroma or bleeds could lead to intracerebral hemorrhage. So you can look at the brain stroke in terms of the passenger, that is the clot causing the occlusion, or the passage, the vessels because of atherosclerosis or vasospasm, or the power, the brain injury. So in preventing stroke, you can look at these three aspects and tackle them. Okay. With regard to the passage, that's the blood vessel. For the intracranial, there could be in situ thrombus within the vessels, commonly in the small vessels. This is commoner in blacks and Hispanics, commoner in females associated with hypertension, diabetes, and metabolic syndrome, leads to stroke in intracranial vessels. So the middle cerebral artery, the anterior cerebral artery, the posterior cerebral artery, and their branches. But for the extracranial vessels, that is for the major arteries before they enter the brain. Most often you find endothelial plaques or due to rupture of the plaque, such as at the carotid bifurcation. This is commoner in whites. This is commoner in males, associated with dyslipidemia, associated with smoking, peripheral vascular disease, coronary artery disease, and some genetic factors. And this is known to cause more TIAs than stroke. It can cause stroke when those clot embolizes and goes to the brain. But if they are in situ, they mostly come TIA when the occlusion is severe. So if you find a patient that developed TIA, you must do carotid Doppler for that patient to rule out carotid thrombus or carotid plaques or evidence of stenosis. Okay, this is a picture showing areas where those stenosis can occur. The origin of the vertebral artery, the right and left, at the bifurcation of the carotid artery bilaterally, and then higher up, and then at the basilar artery, and then at the middle cerebral artery, and then at this place also. So clinical features of stroke, you could look at it from clinical aspect, pathological aspect, etiological aspect, anatomical diagnosis. So in diagnosis stroke, you make use of these four parameters. These are the several areas of the brain, including showing the function of the brain. This is the frontal lobe. This is the Broca's area for speech. So speech is on the left cerebral hemisphere for the right dominant individual. So if we point the patient that have left-sided hemiparesis, then there is a possibility that he will develop speech impairment, and Broca's aphasia is one of the ability to talk, but they understand and they comprehend. While the Wernicke's area is the one in this one. This one is for reception, speech reception, okay, and understanding of speech, while this one is for verbalization. This is the primary motor area where the corticospinal tract or the pyramidal tracts emerge, and then the primary sensory area where the sensory nerve start, and then this is the auditory area. So this is hospital area for vision, primary and secondary. So any vessel supplying any of these areas, so many others, if they are occluded, then patient will develop symptoms related to the function of that area. Okay, this is why you can look at it later on to see the different function of the brain, and then to know that whichever one that is affected, patient tends to. And it's also important to remember the human homunculus that they teach us in physiology, whereby the legs are buried in between the two hemispheres supplied by anterior circulation stroke, while the superlateral surface, this face is looking at us, is supplied by the middle cerebral artery. So if you find out that the patient has more upper limb weakness than lower limb weakness, then you know that it is likely to be middle cerebral artery, because this is the area of the brain that is affected. If you find a patient that has lower limb, one-sided lower limb weakness that is more than the upper limb weakness, then the possibility is that that patient has what? Anterior cerebral artery stroke. Okay? But sometimes patient can present to you with paraparesis, that you start thinking of other differential, not knowing that it's parasagittal meningioma. A brain tumor can sit in between the hemispheres, and it can also occlude, it will also cause paralysis, this time around on both sides of the legs because it is obstructing the vessel anterior cerebral artery from both arteries, from both left and right medial aspect of the cerebral hemisphere. Okay, so this is a coronal section of the brain showing deep structures in blue that are supplied by the end artery, the lenticulostriate artery, which can be affected. This is the caudate nucleus. This is the putamen. This is the globus pallidus. I don't want to go into detail nothing, but the internal capsule is somewhere here. Stroke in the internal capsule tend to present dense hemiplegia because as the corticospinal tract emerges from the cortex, they are spread out. But as they pass through the posterior of the internal capsule, they are like jam-packed. So a small bleed or a small infarct will cause maximum impact. So you should take note of that. These are arterial circle of Willis, which and their branch. I don't want to go into the detailed anatomy, but this is the anterior cerebral artery. This is the medial cerebral artery. This is the internal carotid artery. This is the optic chiasma. Okay, and then this is the basilar artery, and then that gives rise to several branches. So if you cut here up, is anterior circulation. If you cut here down, is posterior circulation. Okay, this is the picture. So any of these artery that's affected, the patient will manifest the symptoms of the area that the symptoms of the function of that area will be impaired. Okay, so this is what I've been explaining. We know that the posterior circulation involves the large vessels, the vertebral artery and the main branches, and then the anterior circulation, mainly the MCA and the ACA, and then the posterior circulation supplies the brainstem, the cerebellum, the thalamus, the occipital lobe, and then brainstem syndrome. Okay, so these are some of the clinical symptoms that the patient will manifest depending on the area that is affected. Okay, so these are the symptoms that the patient will meet cerebral artery. Patient will present it with contralateral weakness or sensory loss, aphasia if the left hemisphere is involved, as I earlier mentioned, hemianopia. For anterior circulation, contralateral lower extremity weakness with sensory loss and sometimes bladder dysfunction. For ophthalmic artery, patient will develop with ocular symptoms. For anterior spinal artery, this one, anterior spinal artery, this one, patient will present with paralysis and loss of pain and temperature sensation below the lesion. Okay, and then vertebral artery insufficiency, patient will present with dizziness, diplopia, dysarthria, dysphagia. The 4 Ds are because of vertebral artery insufficiency or vertebral artery stroke. Posterior inferior cerebellar artery, patient will present with lateral medullary syndrome, and the anterior inferior cerebral artery, patient will present with lateral pontine syndrome. All these are syndromes that patient can present. Superior cerebellar artery, patient will present with this superior cerebellar artery, this anterior inferior cerebral artery, and then the posterior inferior cerebellar artery is this one. So for superior cerebellar, patient will present with cerebellar stroke, vertigo, headache, vomiting, and even ataxia. For posterior circulation, visual problems. And then if you ask the patient, normally if you draw something on a patient's hand, he should be able to tell you that you are drawing A or you are drawing O. And if you hold something with his eyes closed, he will tell you that I'm holding a mango, I'm holding a tennis ball. But if they have cortical stroke because of maybe posterior circulation stroke, for instance, if you draw something on their hand or you give them to, they will not be able to tell you what they are holding or what you are drawing. Okay, that's cortical blindness. So this is a reminder corticospinal tract, whereby up to the medulla before it deposits, patient will present with contralateral symptoms. But anything below this, patient will present with ipsilateral symptoms. Okay, so these are some of the anatomical considerations whereby cortical, that is larger, the most upper part of the cerebral cortex, commonly thrombotic, but for the subcortical structures that I showed you in blue, patient could have lacuna strokes and others. Okay, they can have infarct and hemorrhage also within those structures. Okay, and then Basal ganglia, they have other symptoms such as dystonic posture and abnormal movement of the body. They are having abnormal positioning or posturing in addition to the stroke. Okay. So for the pons, patients tend to have loss of consciousness because the pons is a very narrow area. So small hemorrhage or small infarct also give a maximum impact and symptom with loss of consciousness. So this is our poor man or poor country or poor facility or poor state city that we use the WHO criteria in the absence of CT. We are all familiar with this, whereby when you have more of loss of consciousness, headache, vomiting, and then loss of consciousness, you're thinking of cerebral hemorrhage. But if patient had some TIAs and the onset is not too sudden, you tend to think that we assume that it is infarct, but its CT is the hallmark of everything. Okay. Okay. So in brainstem, they tend to present with cross hemiplegia, and then in midbrain syndrome, patient can present with Weber's, Benedict syndrome, or Cloud syndrome, or Perinaud syndrome. Most often they present with inability to adduct one of the eye plus weakness and some other symptoms like that. For the Weber's patient, they will have this ipsilateral oculomotor nerve palsy with contralateral weakness. For the Benedict syndrome, patient will have ipsilateral oculomotor nerve weakness. So if you see a patient with into one direction, there are several causes actually. So for the pons, they tend to have hyperexia, deep coma, and meiosis. For the medulla, tend to present with medullary syndromes. They tend to present with
Hello, sorry, our presenter. Please just try to summarize. The topic is quite interesting and broad. But we are time bound, so just try to summarize.
Remember, thank you very much. Remember, the medulla contain vital structures, so you may have things like respiratory abnormality, even apnea. You may also have some cardiovascular instability with your BP and your pulse rate. You may also have some other features that temperature. I mean, so other features because of medullary affectation. The cerebellum. We mentioned some of the features, but remember, if there's a bleed in the cerebellum, it's a neurosurgical emergency. Lacuna stroke, I mentioned part of it during the discussion, and then these are the concept of penumbra and umbra and penumbra. We're all familiar with this, and then we should also remember stroke and HIV. I've also mentioned stroke mimics, such as the ICSOL that are commonly seen in retroviral disease patients. And in retroviral disease patients, they also have other things, not just due to ICSOL. They could have vascularity because of HIV vasculopathy. They could have immune complex deposition. They may be toxic, direct toxic effect of the virus on vascular endothelium. And then they may induce antiphospholipid antibody syndrome in retroviral disease patient, whereby the presence of all these antibodies could also predispose patient to stroke. Stroke and COVID is a known phenomenon. It's it's an established cause even among Nigerian patients. And then these are some of the information on that. So imaging is the gold standard, and then there are several imaging, CT, MRI with different series, CT perfusion, MRI perfusion, susceptibility weight image in acute stroke, and then apparent diffusion coefficient, so many other imaging that one can do. But remember, the initial CT in stroke is non-contrast CT to rule out hemorrhage. And then you give contrast if you are suspecting maybe things like an infection, like meningitis or abscesses or some other things. That's when you give contrast, but most often order for non-contrast CT. But in centers that have facilities, you just do CT perfusion and some other advanced series. So there is need for stroke unit. We are not yet there, but we hope that will be there soon. But individually, if we cultivate a good mindset, we should be able to invariably improvise and then offer some of the first services that are obtained even in the soil, in the ICU, in our various facilities. Antiplatelets are proven to be effective. Thrombolysis are proven to be effective. And then the use of knives also, such as endovascular thrombectomy and then decompressive craniectomy in some situations. Carotid enterectomy, coiling or gluing or flow diversion aneurysms, and then bypass surgeries, all could be done. So both use of conservative management, medical management, and then the use of knives in surgery. So this is a timeline care for stroke. It is said that ideally, emergency physicians will see a stroke patient within 10 minutes, and then that evaluation within 10 minutes. Stroke physician notify within 15 minutes. CT scan is completed within 25 minutes. CT interpretation is obtained within 45 minutes of arrival, and then IV alteplase should be initiated if indicated within 60 minutes. So this is acute ischemic stroke care map, whereby each and everyone is supposed to do this whenever we see a stroke patient. Determine the time of onset of the symptoms, obtain non-contact brain CT, calculate the NIHSS score to know the score severity. This is what is to know the score severity. Check for glucose, if hypoglycemic, correct, maintain oxygen, check temperature, treat fever, obtain neurology consult immediately, keep patient nil per os only if they have dysphagia or a positive swallowing test. Okay, give aspirin or clopidogrel unless ICH or through allergy. There is a paper that says that in a center where there is no CT, giving aspirin doesn't cause much harm, even if the patient has intracerebral hemorrhage. But I don't think it's a randomized controlled trial. And then try to maintain arterial pressure over 100. And then obtain ancillary testing such as screening for risk factors and other things. Okay, these are the phases of temporary management, contemporary management of stroke, where it is divided into acute emergency care, do necessary resuscitation, the hyperacute within 4.5 to 24 hours, the acute phase within 48 hours, the early subacute phase within 2 to 4 weeks, and then the late subacute, where you do maintenance rehabilitation, psychological support, and preventive measures. Then the long-term chronic care, which form most of our patients are clinic. You do psychological support for depression, prevent recurrence, to look for other risk factors, and then try to rehabilitate them. So these are some so the principle of management generally involve resuscitation, radiologic evaluation, non-contrast brain CT, and then the reperfusion using thrombolysis or thrombectomy in facilities where they are available, and then recurrence prevention, retard progression by treating comorbidities, and then reduce risks and treatment complications, risk factors modifications, and then rehabilitation, physiotherapy, occupational and speech therapy. Resuscitation, you ensure airway, breathing, and circulation are stable, motor vital signs round the clock. And then you do serial neurological assessments and NHI score. That's the objective way of knowing the level of the severity of. And then you do your radio imaging and then other ancillary investigations. And then there is what is called allowable hypertension within the first 24 to 48 hours in ischemic stroke. You allow the BP even if it is high, because cerebral perfusion depends on high blood pressure. When patients develop stroke, they tend to lose their cerebral autoregulation. So cerebral perfusion is only maintained with that high BP. When you crash that BP, you worsen the stroke for them. And labetalol is commonly used now, which is safer than hydralazine. So even if you are in a center where there's no hydralazine, please don't give more than 5 milligrams at a time. Dilute in a 20 ml syringe with water for injection. Give 5 minutes and monitor the patient to see if the BP have dropped. If the BP have not dropped, give another 5 milligrams. I don't give more than 10 milligrams of adrenaline. Once you give the 20 milligrams, patient will go into hypertension and you worsen the stroke. You can control the BP to certain extent, reduce it a little If the mean arterial pressure is more than 145, or the diastole is more than 120, and you control the rest arterial pressure by several methods, including raising the of the patient, hyperventilation, mannitol, and then by the third day, you can begin to bring down your BP. Okay. Sometimes once the raised ICP is controlled, the BP will come down. Even if BP is 200 over 110, don't touch it in ischemic stroke. Okay. But for the hemorrhagic stroke, your target is supposed to be less than 140 over 90 in less than 50 years or lower in diabetes, and those over 50 years. You try to reverse the anticoagulation in hemorrhagic if the patient anticoagulation, and then you do clipping or coiling if it is aneurysmal ICH or SAH. Okay, but for the ischemic, you do thrombolytic therapy. Altiplase is given within 4.5 hours, but this time has been extended to more than this now. Okay, clot retrieval, you do mechanical thrombectomy where they pass gadgets to go and just remove the clot. This is done if the vessels are large. Those are the vertebral or large vessels occlusion. Okay, and you can do it within 6 to 12 hours. These are the current, these are the standard management. But here we do more of conservative management. In stroke management, please always check for positive swallowing test. If patient cannot swallow the spoon of water that you give him, or he retains it in his mouth, or the water is leaking from his mouth, that means that patient is having swallowing problem and he is at risk of aspiration. And aspiration is the commonest cause of mortality in stroke patients. So pass NG tube, pass to pass NG tube so that the patient can be fed through NG tube and be given medication. You should check for this swallowing test every day. If patient has any of these treatments that I mentioned, call it positive swallowing test, and you should not feed through the oral. Persuade the relative not to feed the patient without NG tube, especially when it is the commonest cause of death. Okay, there are several supportive care that you can do. You give your normal saline, you give mannitol with furosemide, but you should not give too much furosemide so that I don't tilt the patient into hypovolemia, because our aim is to maintain euvolemia using normal saline. Most of the times we give 500 TDS or QDS. If patient has heart abnormality, we give like BD and then mannitol in between. There are centers that don't give mannitol. Okay, avoid hypoglycemia, control fever. Fever is commonly seen in hemorrhagic stroke, and also ceftriaxone. It was found to increase outcome in stroke patient. The mechanism is poorly understood, but perhaps because of the burden of infectious disease in the low-income countries, so ceftriaxone could help with that. Secondary prevention, you give antiplatelet medication for patient, but you delay antiplatelet if the patient has hemorrhagic stroke until after several weeks. Some say 6 weeks, some said even up to 3 months if there is no problem. So you can either give aspirin or clopidogrel, okay, but clopidogrel is preferred, okay, in ischemic stroke, and then you can give statins. But remember, statins induce myopathy, and some of the side effects of statins include statins induce myopathy. They can cause muscle weakness and then muscle pain and what have you. You give your antihypertensives, and then you encourage lifestyle modification. Okay, long-term follow-up is important. Counsel on medication adherence, regular follow-up, risk factors, assessment and management as needed. And then this is just a summary also of what I've earlier mentioned. Don't forget your physiotherapy. From the one, you can even start physiotherapy, except if you are thinking the patient has a lower limb DVT, so you don't like to mobilize the limb, okay? Treatment is multidisciplinary. Don't forget to invite the neurologist, depending on the comorbidity that the patient is having, the physiotherapist, the occupational therapist, speech therapist, and then some supportive care, such as music therapy, even involving religious leaders to pray for the patient, offer spiritual support. All this will help. And then try to prevent depression as much as possible. Okay, if you notice any raised ICP that is significant, please, you can even invite the surgeon to come and do craniectomy. These are the complications. Early, there could be herniation, there could be hypoglycemia, hydrocephalus, seizures, aspiration, electrolyte derangement from the patient or from your treatment. Okay, intermediate such as DVT. Pressure source can develop within 1 day of patient lying on bed, the unconscious patient, 1 day of lying down without turning the patient using air mattress or water bed, patient can develop that. Orthostatic pneumonia, atelectasis, UTI. Late include disability, cognitive impairment, depression, disease atrophy, contractures, osteoporosis, and death. And the recurrence of the stroke in some patients. And then for some arachnoid hemorrhage, what you are afraid of is cerebral vasospasms and then rebleeding, which is carries high mortality. Okay, cerebral amyloid angiopathy, as mentioned it earlier on. Okay, so you suspect it if patient has stroke and no history of hypertension. But of course, any patient that tells you he doesn't have hypertension, you as a physician, you should also look for symptoms of chronic hypertension in that patient. You could check for arterial thickness. You understand? You can also check for locomotor brachial, which we all know and we all do. We should try to be doing them. Patient tells you I don't have hypertension, check for arterial wall thickness, check for locomotor brachialis, check for loud A2, okay, and check for some cardiac features of hypertensive heart disease. So you can tell the patient you have hypertension for years, but it's just that you don't know or you didn't present to the hospital. So you manage as such, okay? So okay. So no effective treatment for cerebral amyloid angiopathy to treat conservatively. If the blood is large enough, you call surgeon to evacuate, just as in intracerebral hemorrhage. Okay, so these are stroke differentials. And there are several differentials of weakness of stroke, irrespective of the type. Okay, these are some of the eligibility criteria for IV alteplase. In case some of us find ourselves in a place where alteplase is given to lyse the clot. There must be diagnosis of stroke in a patient more than 18 years, symptom onset less than 4 hours, 0.5 hours, and now the symptoms is extended actually. And because of this tissue-based approach in the management of stroke, a patient that presents with stroke 24 hours after might be different from the person that presents with the stroke after 8 hours. That present with after 24 hours may have a reasonable penumbra that is good enough for you to even give your thrombolysis. That present within 8 hours might have a very severe symptom that you might not be able to give this. So treat your patient based on what you found. There are individual variation. These are the exclusion criteria and exclusion criteria. I'm rounding up. These are also for alteplase. So before you give alteplase to screen the patient very well.
The next 5 minutes.
Okay, these are relative exclusion criteria for thrombolysis, that the use of alteplase. Okay, so before you give alteplase, you have to really do work on the patient. Okay, so prevention could be primordial, primary, secondary, tertiary, quaternary, but you also look at it from the passenger and the power. The passage is the blood vessel, the passenger is the clot, and the power is the brain. You can work on them to prevent stroke. And then there are these life essentials that the recent 2024 American Medical Society guideline for the primary prevention of stroke, and the family physicians should please take note because they see most of the patients that during in their clinics several years before they develop stroke. So the primary care physician can do a lot in trying to ensure that this life essential aid is the basic that the patient can do. And this include taking Mediterranean diet, adequate sleep at least 7 hours in the day, avoiding smoking, regular checking of BP and temperature measurement, checking on the collateral, and then treating them as adequately as possible, maintaining adequate weight, checking for glucose level and all the other investigations that are done for diabetes, and then making sure a patient is euglycemic, and then maintain exercise. So this life essential aid should be upheld by all of us, and most especially the primary care physician, because sometimes before they present to the neurologist or a cardiologist or others, this must have been ongoing for decades. So the primary care physician should ensure this on our patient, as you are all aware of. Okay, so stroke and pregnancy outcome. Advanced pregnancy outcome is also associated with stroke. So the gynecologist should also please take note. Any of the pregnancy problems such as eclampsia, pre-eclampsia, chronic hypertension in pregnancy, gestational hypertension, please let's ensure that we manage that adequately. And then number of pregnancies that are affected by miscarriage if there are more than 2. If you ask a patient, if you see a patient with this condition, you ask number of pregnancies that the patient had with miscarriage. If they are equal to or more than 2, preterm birth more than 1 or equal to 1, high blood BP including postpartum more than or equal to 1, so for gestational baby more than 1, gestational diabetes greater than 1, or greater or equal to 1 pregnancy, abortion placenta in more than or equal to 1 pregnancies, or still more than 1 pregnancy, you evaluate the patient and manage vascular risk factors. This is a class 1 indication. So the gynecologist that sees this patient among us, or even us, we should try to ask this question. If they are present, they should try to evaluate for cardiovascular risk factors and manage, because all these other pregnancy outcome are also risk factors for stroke. If they say something is class 1, it means it is important and it is found to be useful and you should do it. Okay. So contraception, most of our contraceptive medications are low dose, so they don't cause stroke per se. But if the person taking it have other risk factors that are not controlled, then it may increase the risk of stroke in them. Okay, so especially, but all these ones that I mentioned earlier on, they don't have that factors. The first 1, 2, 3, 4, 5, 6, 7, 8. Okay, so thank you very much. These are my references. I use slide from our top neurologist, and then in the country, I also use some of the slide from update of the South College of Physicians. I use Medicare Radiopedia up to date, and then Start Pulse. Okay, so thank you very much for your time.
Wow, thank you very much, Dr. Nuhu Abubakar. I think you've done justice to this topic. And sorry for rushing you, because I know how important this topic is to all of us. And even if we give you 4 to 5 hours, I believe you'll still be talking. The stops are there. So we are so much grateful. I will leave the floor for the participants to ask their questions. And we'll try to, the presenter will attend to them as fast as possible so that we'll take the second presentation. So the floor is open. In the next 2 minutes, we're going to entertain questions and comments. Thank you very much. So please, let's try to be snappy. We have another important presentation at the corner. Hello, are we still around? Can you all hear me? Okay, I think there is one question on the chat box.
I'm listening to you. Thank you.
Hello, Dr. Nuhu.
I'm hearing you.
What do you do when the relatives and patient refuse NG tube, as we see here most of the time?
This is a common problem actually. You need to cancel them, and canceling is not just one session. First, you need to place the patient on nil per hour and tell the relative that you are not going, because if he takes any meals, you will aspirate. And aspiration is the commonest cause of death. So we try to cancel them, and canceling is not just one session. You do it later, you do it later, you do it until you are able to convince them.
Okay.
So if they still refuse, then despite everything, then ethical issues will now come up. Honestly, you could actually report to your senior so that the patient's interest will take precedence. So you invariably will be forced to act paternalistically to help the patient. Okay.
All right.
So
thank you very
other
much.
methods include parenteral nutrition. It has its own side effect, but another option is parenteral nutrition as well. Yeah, Parental nutrition is another option that you could employ, but it's expensive. And try to prevent hypoglycemia as much as possible. But remember, dextrose-containing fluids are not advisable in stroke. Dextrose-containing fluids are not advisable in stroke.
Okay, thank you very much for that answer, the explanation given. Please, I believe that we still have questions because this topic is too important to be ignored.
Yes, so, especially in states where there are no cities. Where there are no cities, it's a very important topic.
Yes, yes. So we can still write down our questions and later we can still ask. And please, let's pay attention to the next presentation, and that is Lassa fever and update the need for vigilance by healthcare workers. And that will be taken by our very own Dr. Micah Obaro, a Chief Medical Officer working with the Federal Medical Center, Jalingo. Thank you very much. Let's pay attention and jot down our questions and ask after the presentation. So you have the floor.
Okay, so let me unshare.
All right, sir. All right.
Let me unshare so that you will.
It's okay, sir. Thank you so much.
I've unshared now, so you can share his own.
All right. Good morning. Good morning, colleagues. Senior colleagues. Enjoyed the last presentation. I also want to thank the CNA for this privilege to take us on this update on the on Lassa fever and update and the need for vigilance by the healthcare workers. Thank you very much. We will be following this outline: introduction, background, epidemiology, case definition, diagnosis and clinical management, and then overview of the 2025 Lassa fever outbreak as at Epi week 17, that's 21st to 27th April. Then what we have for the week 18 that followed, and then where we are in Taraba State now, the challenges, the conclusion, and then my references. By introduction, what I'm going to be saying, many of us know them, but we want to remind ourselves. And we know that Lassa fever is now endemic in Nigeria. Also, the Taraba State is one of the 6 high-burden states. Others are Edo, Ondo, Taraba, Bauchi, Ebonyi, and Plateau. So it's in of real concern to even the NCDC. The fight against Lassa fever has been on for 55 years, which means that it's older than many of us on this platform, apart from our fathers and our senior colleagues. And it was first discovered in Lassa town in Borno State. Also, the background, Lassa fever is an acute viral hemorrhagic illness caused by Lassa virus, the RNA virus, like we know. It was first of all identified in 1969 in Lassa, Borno State, where two missionary nurses were infected and they died later on. Also, is transmitted primarily from humans to humans via zoonotic spill over by rodents, mainly in the sub-Saharan Africa and settings. The rodent in particular is the Mastomys natalensis, like we know. Secondary transmission, which is of utmost importance to us, especially healthcare workers, is from human to human. Because the doctor doesn't go to the bush to look for rats. He doesn't go hunting all those stuff, even though some people say it's the delicacy to them. But we get it to care for the patients, and that's how people get infected. And it presents with non-specific clinical features, which is similar to many febrile illnesses around. So that's why we have to have a high index of suspicion. In about 80% of cases, it is symptomatic. Like one of my chiefs will say, he said that most of us that work in the treatment center, she's sure that we have gotten the infection, but we are asymptomatic, probably because of some maybe little immunity that we have gotten. Also, one of the challenges we are having is late presentation. When people present late, it leads to high mortality, and it imposes significant health and economic burden on families, communities, and nations. So for now, there's no approved vaccine yet, but they are working on it. Some groups are doing vaccine trials. They were here early this year to try to see if FMC can be one of the centers for the vaccine trials. Epidemiology, this is just a map showing the West African sub-region, and you can see from this that it's endemic in some areas, and some countries have evidence while some they're not applicable. For instance, we can see it in Guinea, Sierra Leone, Liberia, and then Nigeria is the epicenter with so many states affected. This slide is just showing part of the epidemiology, that there is surveillance gaps and all those other things that we talk about. And it's telling us about the fact that we have 100,000 to 300,000 cases per year in the whole of West Africa. I will show us some data later on to talk about that in Nigeria. Yes, formerly we used to have a seasonal pattern. It still obtains in many, many states. But in Taraba State, what we saw last year and this year is not seasonal. Of course, it peaked during the dry season, December to April, but last year we had it every month. We had at least one case, and it's what we are seeing even this year again. So it's seasonal in most places, but it's not in Taraba State again. That's why we are talking about it. And there are two peaks that have been observed in some places like Sierra Leone, June to August, apart from the normal December to April. This is the map of Nigeria showing states that are affected. The ones that are not affected, they are just one or two, and they are not so much. And we can see that Taraba State is among those that have as high as 11 to 40 cases in the season. So that is why we are seeing this. Yes, so this is from the National CTREP, EOC CTREP for Epi week 17. That's from 21st of April to 27th of April. We have had 160 cases for that week, and this case were from 4 states, 8 local government areas. And from those 160 suspected cases, 11 were confirmed, and 1 healthcare worker was among the 11. From those, for that week, we had 3 deaths, and the case fatality ratio for that week is 27.9%. Now, the cumulative from January 1st to 27th is a total of 4,672 suspects.
It's not you the last time to stop calling my name there.
This is from 18 states and 93 local governments. Taraba is one of them. In 34 states from January to now have at least 1 suspected case. That's why I said in the previous slide that it's only 1 or 2 states that have not reported any suspected case. Out of that 4,672, we have had a total confirmed case of 770, which is 15.1% of the total that were suspected. And the healthcare workers that were infected were 22 from Ondo, Bauchi, Edo, Taraba. Taraba, they are reporting 3 here, but it's actually 4 because we've had 1 doctor, 2 nurses, and 1 lab scientist. The deaths total of 135, and the case fatality rate is 19.1. This case fatality rate is high, but the sad thing is that it's even higher for Taraba State, where it's up to 46%. Now, this is the reporting for the week, which should be about last week, and Taraba State had a total of 3 cases, and the treatment center is FMC Jalingo. We have the report from other states there from the National CTREP. So in Taraba State, as I said, this is the summary from the Taraba State EOC CTREP. We have had a total of 336 samples that were tested. We are not talking about suspected. Suspected is more than this, but the one that we actually tested is 336 from 1st January 2025 to date. And then the result shows that 128 were positive, and 208 were negative. And out of that 128, we lost 59 patients. And that's why I said that the case fatality rate is very high, because it's almost 50%. there are a lot of factors. We'll look at them later on. This one is distribution by local government. You can see we have 4 local governments that are topping it. We have Jalingo, followed by Bali, followed by Adokola and Gaso. In some other local governments, we have 1 or 2, and then we have Yoro and Zing. They've not reported anyone. Kurumi, they have not reported anyone, and also Usa. For Kurumi and Usa, I think is the distance. And then the awareness of the people that are there, but it's left for discussion and further investigation. By sex distribution, we have more males that are affected, 59% compared to 42% of females. Talk about age and sex distribution. This year, we have had all ages. We had a 74-year-old prof that was infected and admitted in the treatment center. We also had a 75-year-old woman that was also infected and admitted in the treatment and treated. The good thing is that they both responded and they were discharged after 10 days. But many were not so lucky. If you look at this age group, we found that the mean age is around 30 to 39 for both males and females. So that's the working group. Then we have those more cases in those 2 groups. This is the map of Taraba State. The other one we did was like a pictogram bar chart, but this one is showing the different local governments, and you can see from the different colors that we have Jalingo, Bailey, Gasol, and Adokola reporting more cases compared to some of the other people. So every local government is affected, apart from Usa, Kurumi, Zing, and Yoro, as I said. So we move on to the case definition. And we just want to say this because it will help in clinical decision making and also guide in the management. As I said earlier on, the symptoms and signs, they are non-specific, they mimic most common illnesses around. So number 1, we have alert case, and that's any person who has an unexplained fever, like unexplained fever, that's malaria and other common causes of fever that we have around, have been ruled out, with or without bleeding. Let me say at this point that even though we say it's a viral hemorrhagic illness, some people present without any bleeding. In fact, in a training we attended in 2017, they said for you to see bleeding, that means it has advanced. Many of them, they have microscopic hematuria. That means you may not see it obvious, it's not obvious. That's why we normally insist on doing a urinalysis. Then we also said that for the alert case can be any person who died after unexplained severe illness with fever and bleeding. That's an alert case. The case in Edo State that triggered all this, I think around 1999, was that of a man that died, he fell ill and died, and before the burial, his children came from out of the country and they were doing last office, opening the casket and going around. And before you know, those children, they took ill and they took ill. Some of them didn't survive it, but it raised the suspicion and they began to investigate. And that's why today, IRA is the epicenter of treatment management for Lassa fever. So this issue of last office, we should look into it very, very well, whereby they open the office, I want to see the person for the last time, and all, some of them, they do baiting of the corpse and all those things. Is not advisable. So you have suspected case, and that's any patient with fever for 3 to 21 days. We say 3 to 21 days because that's the incubation period. And the temperature, we talk about 38 degrees centigrade. But we've seen whereby we have 37 and they are still Lassa fever. So, but the emphasis is that the temperature must be measured. You don't just touch and say it is this patient is fever. You must measure it yourself. And then the suspected case, they can have one or more of the following: vomiting, diarrhea, sore throat, myalgia, generalized body weakness, abnormal bleeding. So with all this one, then in the neonates, we have maternal Lassa fever, plus or minus signs and symptoms of Lassa fever. A probable case A probable case is a suspected case who has one or more of the following complications: hearing loss, facial or neck swelling, seizures, restlessness, confusion, hypotension, whereby the systolic blood pressure is less than 90 in adults and in children is about less than 70. We have oliguria, where they are not making urine less than 0.5 ml per kg per hour of urine for over 6 hours. We also have abnormal bleeding, maybe bleeding from puncture sites. Or then there may be any of the following supportive laboratory evidence, like urea, microscopic hematuria, as I mentioned earlier on, elevated urea greater or equal to 9.1 millimole per liter, elevated creatinine greater or equal to 132 millimole per liter. You can also have elevated liver enzymes and then reduced platelet. In this center, what we have noticed is those that come with seizures. You just see somebody came and they say it's ordinary fever. Before you know, you start convulsing and the prognosis is very bad. So those are probable cases. Then the confirmed cases, all we have discussed above in both the alert, the suspected or probable case, with a positive laboratory test, which is the Lassa PCR test that is done. And the good thing is that it's done in Taraba State here in FMC, although we've been having challenges with reagents of recent. So we move on to the diagnosis and clinical management. We say diagnosis is made after proper history, thorough examination, followed by a confirmation of the Lassa PCR result. It's not enough to just see a patient and say Lassa. You must take a good history. We have talked about other things. We said it mimics many of the common illnesses around. Then we talk about examination. Some people are afraid to touch the patient. No, you don't need to do that. Once you are properly kitted, you can examine the patient and then take the samples so that it can be tested. Then we also watch out for other comorbid conditions which should be managed, like hypertension, diabetes, CKD. There's a patient that came, a young man, I think he was in his late 30s, and he was not a known diabetic, but all he has been feeling of recent, and by the time we did the random blood glucose, it was unrecordably high. Now, because of the suspicion of Lassa, it was like almost abandoned. Before we could start correcting and everything, the young man passed on. So we should watch out for other comorbid conditions and treat them. Then after diagnosis, the patient are managed in the Lassa isolation ward. They are not managed in the common ward. We have had situations whereby we suspect and then we move to a holding area, and when the result comes confirmed, we move to a treatment center. For now, ribavirin is the general accepted drug of choice. It is not given for alert or suspected cases, but is given for probable and confirmed cases. Even if the result is not out and it's a probable case, like when they start having seizures or convulsions or other things that I mentioned earlier on, we start the ribavirin. It's given IV. And for the alert and suspected cases, you put them in a holding area. Like in our center here, we have a place in the accident and emergency that is delineated for them. And then we put them there, commence IV fluids, we commence antibiotics and treat as appropriate, while we take the samples and also notify the relevant authorities. Here, once we get it, we notify the local government DSNO and also the state DSNO and the incident manager, so that they are all in the picture, and the lab focal person is also notified. And for probable cases, as I said, we manage them in a treatment center. In FMC, we have single rooms whereby we can keep probable cases that we are waiting their results, while we also commence ribavirin IV. Patients are also assessed for possible complications, because there can be complications from the illness itself, and there can be complications from the